Good.
So are you going to be following campaigns around? Or
Not as good as the one
no, I
flunked out
just
of.
do the health stuff. I'm guessing there will be a fair bit of
The
it.
dean wasn't enthusiastic about my presence,
Tom, you
however.
ready to go?
All set.
Okay. Good afternoon. Thank you all for coming, and welcome to the Woodrow Wilson International Center for Scholars and our Directors Forum this afternoon on the Seniors Entitlement Crunch. My name is Mike Van Dusen. I'm Deputy Director of the Center. Our Director, Lee Hamilton, unfortunately could not be with us. He had previous engagements in New York City and is there today, but he sends his warm regards to his two former colleagues from the Congress, Senator Conrad and Gregg, and his best wishes to the other panelists, including one who will be here in the fall as a fellow, Kimberly Morgan. We welcome both her and Julie Rovner with us. For those of you who are new to the Center, let me just tell you a little bit about who we are. The Woodrow Wilson International Center for Scholars was created by an act of Congress in 1968. It is a public-private institution, receiving roughly 30% of its budget through an appropriation by the Congress. The Wilson Center is a nonpartisan research institute that unites the world of ideas and the world of policy, and serves as an accurate and impartial source of information. The Center fosters research and dialogue and promotes a neutral forum for policymakers, scholars, business leaders, journalists, and the public to examine pressing issues of the day from historical and policy-relevant perspectives. In doing so, the Center is a living memorial to our 28th president, Woodrow Wilson, a man who was both a scholar and a national leader. We are especially honored today to have a team of very distinguished U.S. Senators to address this forum on a public policy issue of growing concern, the projected insolvency of Social Security and Medicare if Congress does not take corrective action. They are both well known as fiscal watchdogs and have demonstrated on numerous occasions that bipartisanship in Congress is not dead. Senator Kent Conrad is a senator from North Dakota and serves as chairman of the Senate Budget Committee. He is also a member of the Finance, Agriculture, and Indian Affairs Committees. He was first elected to the United States Senate in 1986 and has been reelected ever since. He was the North Dakota State Tax Commissioner for 5 years preceding his election to the Senate. Senator Conrad is a Democrat. Senator Judd Gregg is a senator from New Hampshire, now serves as ranking minority member on the Senate Budget Committee. He also serves on the Appropriations Committee, where he's ranking member on the subcommittee on the State Department of Foreign Relations. He was first elected to the Senate in 1992 after serving 2 terms as governor of New Hampshire. Prior to that, he was a member of the U.S. House of Representatives from 1981 to 1988. Senator Gregg is a Republican. Our moderator for today's Directors Forum and the follow-up seminar at 4 o'clock is Don Wolfensberger, the excellent director of the Congress Project at the Wilson Center. Don has served the Wilson Center with distinction for about a decade now. He is a 28-year veteran staff member of the House of Representatives, most of that time spent on the House Rules Committee, culminating as its staff director. Don retired from Capitol Hill in 1997, coming down to the Woodrow Wilson Center, where he wrote an excellent book on Congress while being a public policy scholar here. Don joined the staff in 1999 when he founded the Congress Project. With that, let me turn the program over to Don Wolfensberger. Don.
Thank you very much for that wonderful introduction, Mike, those warm, welcoming remarks, and you've made my job that much easier as moderator in introducing our first 2 guests. Before we proceed, I would just like to ask you all to please turn off your cell phones and BlackBerries and any other devices, because they have a tendency to interfere with our sound system and our video transmission system. So if you would do that, we'd be very appreciative. We are very grateful today to have C-SPAN covering us live live, and this is also being webcast live on the Wilson Center website, so we're glad for that as well. Let me briefly outline for you what our format will be today, and then I'll turn things over to our distinguished guest. The first hour of the program is what we'll call the Directors Forum, something that Lee Hamilton started shortly after he came down here, and which we'll hear from both Senators Conrad and Senator Gregg. They'll each talk for about 15 to 20 minutes. We'll then allow our two other panelists to ask them the first questions, and if time allows, as I think it may, we'll have some questions from the audience as well. Then at 4 o'clock, they are going to be scurrying back to the Hill to attend to certain duties. I understand there's a budget resolution hanging fire up there, as well as a ag conference report, a few small things like that some people have been involved with here. But I would ask you to remain in your seats at 4 o'clock so that they can leave, and we will proceed immediately then to the second portion of our program, when we'll hear from Kimberly Morgan and Julie Rovner talking further about the issue of the seniors' entitlement crunch. The senators asked me what type of audience we usually get for our seminars here, and I've indicated it's a rich mix. We have some fellows and staff from the Wilson Center, but we also have folks from around town. Some people are lobbyists. There are some from the Hill. Some Hill staff people have signed up, as well as the budget office and GAO and all kinds of mix of folks. We have retirees, and so we always have a rich mix of folks here with varying backgrounds, but always eager to learn new things, as am I. So with that, I'm going to turn things over, first of all, as we do on the Hill, to the chairman of the committee, and we will then hear after him from the ranking minority member, Senator Conrad.
Thank you, Don. Thank you for that introduction. Thanks to all of you for being here. As I listened to my own introduction, I thought about how confusing it must be to people that I got elected in '86 and I've been elected 5 times. If you do the math, it doesn't add up. And the reason for that is in 1986, when I was running for office, I made a pledge. And the pledge I made, unless the deficit were reduced dramatically, I wouldn't seek re-election in 1992. Well, I was elected in '86. And if you remember your history, when 1992 came along, the deficit was not only not reduced, it was at record levels. And so I announced in April that I would not seek re-election in keeping with my pledge. Congressman Dorgan ran for my seat in the Senate. I thought I was leaving the Senate. In fact, during that time, I was approached by the Commissioner of Baseball and asked if I would be willing to be considered for President of the National League in baseball. And so I was going through that process, and then fate intervened, and the senior senator from North Dakota died in September of that year. And the governor of the state called me up and said, "Kent, you've got to run to fill out the 2 years of his term, because our state is going to lose all of its seniority in one fell swoop. We're going to lose all of Senator Burdick's more than 30 years in the United States Senate. We're going to lose your 6 years, and we're going to lose Congressman Dorgan's 12 years in the House of Representatives. We're going to be a state with no seniority." And that day, the news media took a poll, and 2/3 of Republicans thought I should run again, which I took as a very good sign. And so I did run in a special election. The regular election was in November. Senator Dorgan was elected to my seat. I was then, in December, elected to fill out the 2 years of Senator Burdick's seat. So I am the answer to a trivia question, because I am the only senator in history that has served in both Senate seats from the same state in the same day. Now, this is an enormously valuable answer to have in case you're ever in a trivia contest and this question comes up. Perhaps it won't come up, but you're well armed if it does. We're here to talk about the fiscal condition of the country, the long-term imbalances that exist. We all know these shortfalls in Medicare and Social Security, and the underlying difference between revenue and expenditure. All of these things are posing an enormous challenge to us as we go forward. To just put it in some perspective, maybe we could start with this first slide. This talks about the demographic tsunami that is coming at us, the baby boom generation, that creates a demographic tidal wave. By 2050, we're going to more than double the number of people eligible for Social Security and Medicare. And this is not a projection. These people have been born. They're alive today. They're going to retire. They're going to be eligible for Social Security and Medicare. So this is not a matter of some projection. This is not some guess. We know this is going to happen. Let's go to the next slide if we can. In terms of the major retirement programs, and including Medicaid, what we see is that if we stay on the current course, by 2050, 18% of the gross domestic product of this country will be going for just 3 programs. As you know, we're spending in total about 20% for the federal government today. This is if we stay on our current course. Medicare, Social Security, and Medicaid will consume over 18% of our gross domestic product. Obviously, that is not a sustainable situation. You can see back in 1980, those 3 only consumed 6% of our gross domestic product. If we stay on our current course, they will triple. And this is the Congressional Budget Office's long-term budget outlook. That is their projection. Let's go to the next slide if we can. They are also forecasting that if we make all of the tax cuts permanent, we extend the alternative minimum tax and index it for inflation. That is, if we replace the alternative minimum tax with some other measure indexed for inflation, and the Medicare physician payments grow with the higher medical inflation rate, this will be the long-term outlook for the country. This is what will happen to our debt. And as you can see, it will explode. And it will head for more than 400% of gross domestic product. Again, those assumptions are if we make the tax cuts permanent, if the alternative minimum tax goes away, and we have Medicare physician payments growing with a higher medical inflation rate. Let's go to the next slide if we can. This does sort of the same thing, but in a different way. It looks at the Social Security Trust Fund is the blue bar, the Medicare is the blue bar, the Social Security is the green bar. The cost of extending the tax cuts is the red bar, and you can see what happens. We all know that trust funds are going to go cash negative about 2017. You can see that graphically. It's actually a little earlier than that now. And then you can see what happens if you make the tax cuts permanent. And again, this is a CBO assessment. And you can see, I mean, we just go right over the cliff. This is not going to work. And yet this is the course that we are on. Let's go to the next slide if we can. There is an urgency to all of this because within the decade, more than half of the baby boomers will reach early retirement age. So some people think, well, this is way off. We're talking about 2050, but the early trouble spot comes much sooner. In fact, we're in it now. We're going to have an increase of $700 billion in the debt this year. That's before the baby boomers retire. So you know, if you just think about this, we can't pay our bills now. We're not nowhere close to paying our bills now. The debt of the country is going to grow by over $700 billion this year. That's before the baby boomers retire. And 51% of the baby boomers are going to reach early retirement age within the next decade. The point of this is there is very little time to get well here. Those people who think, you know, somehow it's off in the distance and we got plenty of time, no, we don't have plenty of time. This point was made by the head of the General Accounting Office, the Controller General David Walker, in testimony before our committee in January of this year when he said, and I quote, "I believe we have a 5 to 10 year window of opportunity to demonstrate to our foreign lenders that we're going to get serious about this. 5 to 10 years, and it's closing. And I think it's closer to 5 than to 10. Keep in mind we're the largest debtor nation in the history of mankind, and it's getting worse, not better. If we could go to that next slide. So what do we do about this? Well, we know the big drivers. The healthcare accounts are the 800-pound gorilla. That's where the biggest problem resides, and that is the place that we need to urgently turn our attention. This is testimony last year before the Senate Budget Committee by the Congressional Budget Office Director Peter Orszag. I think it's a mistake to look at containing costs just within the federal programs themselves, Medicare and Medicaid. The underlying driver of that cost growth, of the cost in these programs, is the underlying rate of cost growth in the health sector as a whole. And tackling that problem is perhaps the fundamental fiscal challenge and an important economic challenge facing the nation. I think he is dead on. The next slide talks a little about things that we could do that would have potential long-term savings in health care that would help us with Medicare and Medicaid. Many of these have upfront costs. You can look at these bullet points, expanding comparative effectiveness research, because one of the things we know is if you look in different parts of the country, they're doing many more procedures for a certain illness and not getting any better results. We have places in the country that are doing 5 times as many cardiac procedures as other parts of the country, and they're not getting any better health care outcomes. So that's got to be high on our list, looking at comparative effectiveness research. What really works? What is the treatment regime that gets results? Second is coordinating care for the chronically ill. And we did a study a number of years ago with 20,000 patients. And we had a nurse practitioner put on every one of them as a case manager. These are people with multiple serious conditions. And what we found was very interesting. First thing that happened was the case manager went into their homes, got out all the prescription drugs they were taking. On average, they found they were taking 16 prescription drugs. And after review, they found they could cut that in half. By so doing, they dramatically reduced hospitalization, dramatically reduced cost, and got better health care outcomes. I had this experience with my own father-in-law and his final illness. Went down to his house, sat around the kitchen table, got out all his prescriptions. I got on the phone to the doctor. Sure enough, I found out he was taking 16, just like the average. Got on the phone to the doctor. I went down the list. I got about the third medicine on the list. He said, well, Kent, he shouldn't be taking that. He shouldn't have been taking that the last 3 years. Went a little further down the list, 2 drugs. He said, well, he shouldn't be taking those together. They work against each other. That makes no sense at all. Sure enough, we eliminated 8 of the 16 prescriptions that he was taking. And I said to the doctor, how does this happen? He said, well, Kent, it happens all the time. He said he's got me as his family practice doc. He's got a health care specialist. He's got a heart specialist. He's got an orthopedic specialist. All of them are prescribing medicines. Nobody knows. The left hand doesn't know what the right hand's doing. He said he's getting prescriptions at the hospital pharmacy, the corner pharmacy. He's getting them mail order. He's getting them down at the beach. And we got chaos. And he said this repeats itself time after time after time. That has got to be, I think, a central part of addressing these problems. Third bullet, changing provider incentives and beneficiary cost sharing. You know, how does the current system work? Well, if you're in Medicare, you get paid for a procedure. So guess what? We get a lot of procedures. Got to change the incentives. We also need to promote healthy lifestyles and preventive care and have widespread adoption of health information technology and e-prescribing. RAND Corporation says if you had widespread dispersal of information technology, you would save hundreds of billions, well, $80 billion a year. $80 billion a year, hundreds of billions over a 5-year budget window. The other side of this is the revenue side, and I don't think we can leave that alone. I think there's a clear need for tax reform. It just jumps out at you. We have the president's tax cuts expiring in 2010. We have this growing alternative minimum tax problem. It hits 26 million taxpayers in 2008 if it's not fixed. And if you fix it without paying for it, it's hundreds of billions of dollars of lost revenue. We have a widening tax gap, the difference between what's owed and what's paid, a complicated tax code that's hurting compliance. We have this long-term fiscal imbalance that must be addressed, and my own belief is simplification of the code and reform could help keep rates low. Let me just come to the end here by talking about what the former Treasury Secretary said about how to address these problems. He acknowledged the need for a bipartisan approach for solving long-term challenges. He said, you can't do health care reform or Social Security reform without a bipartisan consensus. If we made a mistake, it was not approaching it in a more bipartisan way. And the final slide I want to share with you is what the General Accounting Office found in terms of key elements in successful reform efforts in other countries. One, they found that detailed reform proposals in other countries were generally developed by commissions or other specially established groups. Second, before reform could be enacted and implemented, policymakers and the public generally need to have a shared understanding of the size, scope, and nature of the problem. Third, special groups outside the normal political process, such as commissions, can be used to create a space where the difficult negotiations needed to reach consensus can take place. And finally, whatever the reform process, leadership is key at all stages for reform to be enacted and sustained. That, I hope, gives you a bit of an overview of what we face, how serious it is, what some of the possibilities are for reform, certainly on the medical side and the tax side, and then at least the inklings of an approach that might work. To talk further about that, am I to introduce Judd? My colleague, the ranking member of the Budget Committee, the former chairman of the Budget Committee, someone for whom I have very high regard. He knows this subject backwards and forwards. He also, I think, has an acute sense of responsibility for future generations, and he's an all-around good guy. My colleague, Senator Judd Gregg of New Hampshire.
Get the technology here straightened out. Okay. Thank you, Kent and Don, Kimberly, Julie. It's great to be here today, and I appreciate Kent's kind introduction. I had always thought of Kent as one of the smartest, most capable people in the Congress, certainly on the Democratic side of the aisle, until I learned that he passed up being president of the National League. This is new information, and it clearly clouds that opinion. Kent,
I wasn't actually offered it.
If it was even in the ballpark. Chairman Conrad did a wonderful job of outlining the problem. A little depressing, I'm afraid, when you look at the statistics and the numbers that he related. I'm reminded of that famous New Hampshire story. Maine claims it, but it actually was in New Hampshire. A guy named Oscar Mason was the author of it. And somebody pulled up to him from Massachusetts in one of those fancy BMWs. He's an older guy, he's sitting out in front of his general store, and they asked him how they get back to Boston. And Oscar looked around. Most of you have heard this story. He looked up and looked down that road, and he started to think. He looked up the other road and started to think. And then he said, well, you can go down. And then he stopped, and he said, well, you can't get there from here. And that story was one of his better stories. But I got a good one here from Oscar. Well, somebody did ask Oscar that same question after they'd been driving around a bit, and Oscar said to them, well, I really don't know how you can get there. I have no idea. And the guy in the car said, well, because he was from Massachusetts, said, you don't know a great deal, do you? And Oscar said, well, I'm not lost. We're getting the decibels up here. I can do one more Oscar story. Oscar ran this little general store, And the guys from Massachusetts pulled up in their fancy BMW, there were a whole bunch of them. They jumped out of the BMW, they ran in the store and they bought everything. They bought all the flannel shirts, all the hats, all the beer, all the moose dolls, all the moose pops, everything. They just filled the car right up to the brim, and they're walking out of the store and they turned to Oscar. He said, "Hey, can we take this road back to Boston?" And Oscar said, "Might as well, you're taking everything else." Okay. We need humor in this business because when you look at these numbers, they're not funny. Can we get the chart there that shows the 66 trillion? Not that one, the other one. That one. There we go. This reflects how big the liability is that we confront as a nation. And Kent touched on it. $66 trillion is the unfunded liability of these three programs. Trillion, that's with a T. Very hard to understand what $1 trillion means. So we tried to put some perspective on it because I have no idea what $1 trillion means. But if you take all the taxes paid in the collective history of our country, all the taxes collected, that's $42 trillion. If you take all the assets which we as a country own, everybody in this country, your houses, your cars, your stock, everything, the net assets, that's $59 trillion. That means we have a liability on the books, which we have no idea how we're going to pay for, which exceeds the net worth of the nation. And that means we're headed into some fairly significant fiscal problems, obviously. And Senator Conrad outlined those problems and the impact that they will have on us. The fact that the cost of these programs will essentially absorb every cent of what today we spend on the federal government, which is approximately 18.2% of gross national product. Senator Conrad's numbers are actually fairly kind because he didn't include the net interest to support those costs. If you look at these numbers in the out year, the burden on our children, which is the real issue here, in order to support our generation as it retires, is extraordinary. Can you put up the tax one? It's just not a survivable event for our children. Top rates would have to go to 92%. Median rates would have to go up to 66% of your income. Even low-end people would have to pay 26% of their income. Think about that for a moment. That's just to support these three programs as they expand in the out years. And the effect of that, of course, is that we pass on to our children a government which isn't affordable, which means that their lifestyles will not be able to be as good as our lifestyles, the baby boom generation, which they're trying to support. They won't be able to buy that first home. They won't be able to send their child to school. They won't be able to have the quality of life that we've had. Quality of life will actually go down in this country as a result of the burden of the fiscal costs of these programs on the next generation. And my view and Senator Conrad's view is that this isn't fair and it's not right for one generation to do this to the next generation. As a practical matter, this is mostly a function of the baby boom generation aging into retirement. Now, you'll hear some people argue, and certainly Comptroller Walker argued very effectively, that it's really a healthcare-driven event. Yes, it is healthcare, but healthcare is the symptom. The problem is the fact you got a lot more people retired, twice as many people retired who require healthcare, and healthcare will, of course, expand to meet those needs, and fortunately, it will expand and get better and more expensive, most likely, as we know, and the costs of research will go up. But the fact is that our generation, the baby boom generation, is the generation that's generating this issue for our children and our children's children. And we're in governance now. You know, we're the people who are responsible for government. That's why we, as a generation, have a responsibility to do something about this now. Not only because it's been smarter to do it now. It's like that old Fram oil filter ad. You can pay me now or you can pay me later. And if we begin the process now, the cost of addressing this problem is so much less and so much less difficult for our children. So Senator Conrad and I sat down and thought about, well, how can you approach this? And I think that there's some truisms here that we've got to face up to. And the first is this. If you put policy on the table, if I as a Republican go out and suggest something to address the issue of Social Security, or Senator Conrad as a Democrat goes out and suggests something to address the issue of the tax laws, those policies will immediately be descended upon by a locus gathering of special interest groups who use the fact that we presented a policy as a way to raise money and gin up, energize their constituencies. They'll send out letters and little forms that come out and look like their Social Security check saying, if you don't send money, $25 into me this week, you're going to lose your Social Security check because Senator Gregg made a proposal that's going to devastate you. Or they'll send out one in a little IRS-looking envelope that says, if you don't send your $25 in, Senator Conrad's going to tax it away this week. And it has simply been a truism of our political system that these issues, which impact so many Americans, are such hot-button issues and have been so used for demagoguery and for political advantage in our system that there's no longer capacity to put honest and intelligent policy on the table in the context of discussion that might actually lead to action and not have that policy immediately terrorized and have forced people immediately to take definitive positions which don't allow any action at all. And the last two presidential elections have shown that. If you looked at the policies that were discussed during those last two presidential elections on these major issues, immediately when either candidate set forth a concept, either in tax policy or in Social Security policy, it was immediately descended on, and the well was poisoned, and no further discussion occurred. And you've seen it regrettably to a lesser extent, but that's raised its head in this exercise. So we thought about this, and we said, well, if you can't put substantive policy on the table to move the process down the road towards resolution that's specific, how do you approach it? Well, our view is that if you set up a procedure that drives policy, you've got a much better chance. And so we've taken that approach. It's essentially the concept that if you set up a mechanism which forces policy, which is bipartisan and fair, you'll make progress. Now, we all know, because we watch politics and some of us are actively engaged, and I expect everybody in this room, that Congresses are very good at dealing with the next election, but they're not willing to look at the next generation. And so to get the Congress to look at the next generation, you have to have some really super mechanism that's going to force them to do that in a way that's constructive, not destructive to the process. And so that's what we've tried to develop here. And in coming to this conclusion, and we negotiated this idea for a long time, and we bounced it around a lot, so this wasn't an overnight exercise. We made certain rules of the road. First, that we were going to use procedure to drive policy. Second, that there was going to be no question, but that this approach was going to be absolutely fair and absolutely bipartisan. That nobody could attack this as having an axe to grind. That meant initially that everything is on the table, and it was going to be up to the people who were sitting on the task force to decide what went off the table, what stayed on the table, but that nothing would be off the table. So all the entitlement issues, Medicare, Medicaid, Social Security would be on the table, and tax policy would be on the table. That is critical. Secondly, we thought about it, and we said, we've had a lot of good commissions in this area. We had the Danforth Commission, we had I think it was the Frist Commission. I've worked with a CSIS commission that did what I thought was excellent work, but none of them have ever come to fruition. So we decided that rather than taking a lot of people who didn't have anything in the game to lose, other than maybe a little bit of their reputation, we would take only players on this commission who actually were in the game and who had the power to take the action. So this commission is going to be made up just of people who actually have responsibility for making the decisions. There'll be legislators and there'll be members of the administration. And it's going to be absolutely equally divided, 8 and 8. We have 8 Republicans and 8 Democrats, and depending on how the next executive is structured, there'll be 2 people from the administration, and then from that party there would be 6 people from the Congress, and then there would be 8 people from the Congress from the other party. And it's presumed, although not necessarily the case, that those players would be the key players on the key committees of jurisdiction. Equally important for this task force, not commission, this task force to report, it has to have a supermajority. So there's absolutely no question that the consensus was there, that it was agreed to. Supermajority may be as high as 14, it might be 12, but it will be a supermajority of significance. So of the 16 people, either 14 have to agree or 12. We are still, what do we end up with, 14?
We're still...
Anyway, we're flexible on that. It could be 13. And the concept is obviously there that neither side can game the other. when you have that sort of a supermajority required in order to reach a consensus. Again, everything is on the table. Then, after the agreement has been reached, the issue will be taken to the Senate, and this is, of course, and the House. And this is, of course, where we depart from all the other task force commissions or groups that have been put together. It will be fast-tracked. The policies that this proposal puts forward, that this group puts forward, will have to be voted up or down in both houses. Again, by supermajority, 60% majority in both houses, the Senate and the House. And it will have to be voted on. It can't be amended. Now, this was an issue of significant controversy. Should it be amendable? But we agreed that if you allow any amendment to this proposal that comes forward, what you immediately do is give political cover to those people who don't want anything to happen, or those people who are too tentative to be willing to make a decision. I assure you that if you gave one amendment to the majority and one amendment to the minority amendment would be a philosophical position that reflected their base, and the majority amendment would be a philosophical position which reflected their base, which would give either side enough cover so that they would feel they didn't have to vote for final passage of the product. So even though there is obviously a lot of incentive from a standpoint of the structure of both the House and especially the Senate to allow amendment, we felt that any amendment would basically doom this proposal to defeat and would absolutely assure that progress could not be made and that the seriousness of the proposal would not be focused on. So we basically went with a non-amendable vehicle, which has to be voted up or down. What's the chances that this will pass? Well, I don't know. I think they're pretty good. I think they're pretty good, quite honestly. I don't know what the time frame is, but we were extraordinarily close to pulling this off before we got into the middle of the presidential exercise here. I can represent that the Senate Republican leadership had signed off on it. I believe Senator Conrad would represent that the Senate Democratic leadership had signed off on it. There was interest of significance at the White House. There was also opposition. There was interest in the House with Congressman Hoyer being supportive. There was also pushback. But it is an issue or a proposal that has gained, I think, very substantive credibility and has the distinct possibility of being the process which we will follow, hopefully sooner rather than later. The fact is that you can't deny this event. And Senator Conrad's chart about the fact that population exists is going to create the problem makes that case so perfectly. Also, the undeniable fact is that the next presidency, no matter who it is going to be in the middle of this event up to their ears, because the baby boom generation will be heading into full retirement during that presidency. So there's no way to walk away from this any longer. So I'm hopeful we'll be successful, and I certainly appreciate the chance to work with Senator Conrad on this, and we hope you'll proselytize the idea. Thank you very much.
Thank you both. With that, before we open up to the audience, I wanted to give both Kimberly and Julie a chance to ask the first questions if they had any. So, Kimberly, do you have anything for either of the senators or both of them?
Sure, I'll pose the question to either one or both if they'd like to answer. In listening to them talk about the commission, which I think is a very intriguing idea, I was reflecting upon the many proposals that have been swimming around in the policy space for a long time about how to deal with Social Security and Medicare in particular, be it raising the ceiling on wages covered by payroll taxes, means testing Medicare and or Social Security, or more transformative efforts like a system of private accounts in Social Security or transforming Medicare into a system of private plans. And I was just interested to hear what the senators think about the menu of proposals that are out there, and what package of proposals they think might actually be able to get the kind of bipartisan support that you both feel is so essential for any action on these issues.
Well, do you want to start since you're the chairman?
You go ahead.
Well, we didn't get into specifics. And the reason we didn't get into specifics is because once you get into specifics, somebody opposes that specific and starts to parse the event. Now, from my own personal standpoint, I introduced a bill. It was a bipartisan bill with Congressman Stenholm and Senator Breaux and Congressman Colby back quite a while ago now. It was back in the late 90s, early 2000 period, which would have fixed Social Security, and the elements of that bill are still totally valid. We're not proposing any specifics. Senator Conrad listed a whole group of really good ideas as to how you could get Medicare costs, a handle around Medicare costs, which is really the driver of this whole event. But we're not representing ideas. We're just throwing those out as those are options.
Yeah, I would just confirm what Senator Gregg has said. I think it'd be a great mistake for us to lay anything out as a possible component other than conceptually the way I did, because as soon as you get into specifics, you generate opposition. And that's why we've spent a lot of time on what is a process approach, because we've reached the conclusion the only way this has any chance is you set up a process that leads people down a path to solutions. If you try to start with solutions, you never get headed down the path. That's been our experience. We've seen it time after time. Senator Gregg has laid on the table some things previously with respect to Social Security. I have with respect to Medicare. And I just say to you, I'm convinced, as I think Judd is, we really have to establish this process. We got to get people engaged. We got to have people at the table who have the ability to bring the information to bear to come up with real solutions. And then we got to get our colleagues to vote. We've got to get our colleagues to vote.
I noticed somebody, I think it might have been you, Kimberly, talked about the trigger mechanisms that were floating around in your paper. These triggers aren't working. I mean, we've got a 45% trigger now that was supposed to create an event. It's not working. Why isn't it working? Because there's no event that requires a vote. And until you get to that point, now Rudy Penner has an idea where you basically put entitlements into almost a mechanism like we had in the 90s for discretionary spending, which creates a sequester with a vote. That might have a trigger, but that's a hard trigger. But most of the triggers we have aren't hard triggers, and the hard trigger is the vote on the program that's not amendable.
Julie?
Well, that was actually my question, which is that we do have a real-world example of process driving policy, and that is this trigger. And actually, in the House, it can require a vote, and I think the House Republicans are intending for it to require a vote, and that's exactly what I'm wondering, because it's not really bipartisan, and everything is not on the table in terms of that 45% general revenue trigger. And are you worried that if there is sort of a partisan flare-up over that, is that going to, if not discredit your idea, at least put a bad taste in some people's mouths about it?
Let me just say, I don't think so, because that's not our idea. In fact, that's one example of what we have tried to avoid with our idea. Our idea is everything on the table. Our idea is requiring a bipartisan group to come up with a plan, and it only comes to a vote if a supermajority of that group agrees to the plan. And in our vision, this group would be the heads of the key committees, the head of the Finance Committee in the Senate, the head of the Ways and Means Committee, the head of the Budget Committee, the head of the Appropriations Committee, leadership representatives, representatives of the administration. Because if you look back at what has worked, it has only been a circumstance in which you had a bipartisan group who was able to be outside the normal committee processes that has led to any kind of breakthrough, whether it was Social Security, whether it was out at Andrews Air Force Base. We've tried to adopt a model that's actually proven to work, and we have added to that this requirement for a vote, not just a vote in one body, not just a vote on one issue, a vote on a whole package in both bodies. And, I really think that's what it's going to take.
Fairness, too. It's bipartisanship and fairness. Because the American people will not accept something they don't perceive as fair. And that's the bottom line. These programs are so pervasive and so have such a huge effect on the lifestyle of so many Americans that you just have to have, American people have to have absolute confidence that neither side is gaming the other and that this is a balanced and fair approach, which means, in the end, everybody's going to have to give something.
Yeah, just to back up, what Julie was referring to there as what's pending right now, something that the Congress put into effect back in 2003 with the prescription drug bill, and that is if the Social Security Medicare trustees find that the amount of cost for the Medicare program is going to exceed 45% from general revenues, and the President has to submit a bill to Congress and it has to vote on this. And this was done earlier this spring, and so right now that's on a fast track, and supposedly the committee will have to report by June 30th, and Congress will vote by, I guess, the August recess, or if not, well, then shortly thereafter any member can call this up. So, but it's different from the Commission approach in that this is the President's proposal, you take it or leave it, and so there's no, I don't know if there's, might be a little wiggle room for amendments if they achieve the same savings, I'm not sure. But
actually, the committees can go ahead and do their own bills.
They can still offer their own substitutes.
There's no requirement for a vote in the Senate either.
Okay. All right, let's take questions from the audience. Wait for a microphone, please, and give your name and your affiliation. We have mics on both sides of the room, so let's start with the woman back in the corner there in the last row.
Thank you. I'm Belle Sawhill from Brookings, and let me first commend both of the senators for your leadership on this issue. I think it's terrific. I love your plan for this task force. Anything that the rest of us can do to help, I think speaking for myself, would be happy to do so. I think my question has to do, though, with health care and the issues it raises within the process that you've described. And Senator Conrad, you said that we really couldn't address health care unless we address the entire system and not just the publicly funded programs. And yet I assume that if this task force had to take on all of health care reform, that a lot of people would say that it's going to bog down in that you don't want to have the solution to the fiscal tsunami held hostage to having to reform the entire U.S. healthcare system. So, and also I think although all the kinds of reforms that you listed that are needed in the healthcare system are the ones that many of us have been talking about, and they're all right, they aren't going to save a huge amount of money. At least that's my reading of the literature on that. So would you be open, or can you imagine Medicare starting the process of reform, but not requiring that the whole system be reformed before we do something to begin the process of getting the fiscal house in order?
Yeah, I can't imagine that. I can imagine that this group doing Social Security, because frankly, Social Security is relatively easy to resolve. And I can imagine them doing round one of health care reform, including substantial steps in Medicare, round one of tax reform, with more still to be done. And I can imagine them taking an incremental approach. I'm under no illusion that this group solves all of the problems for all time. That's not going to happen. But if we could make meaningful progress on all of those, that would be an enormous contribution. I also think it would be a confidence builder for Congress and the administration. And I think it's absolutely essential that we do this and that we begin sooner rather than later. I mean, the clock's ticking. And it's so easy to kick this can down the road. It is so easy. It is very hard to actually focus and say, look, we can't let this just drift. If we do, the solutions become more and more draconian.
Okay, question right here.
Hi, I'm Dr. Caroline Poplin. I'm a general internist and a visiting fellow at the Center for American Progress. In answer to the last question, very often the private sector in medical affairs follows what Medicare does. What I wanted to say is that there are some administrative things that CMS could do, changing the relative values for certain kinds of medical services that are now set by, in essence, a committee of the AMA called the RUC in secret, and then given to Medicare, and Medicare passes 90% of those. another administrative thing that CMS could do without bringing the whole Congress to bear on it would be to risk adjust the patients so that, for example, if I were seeing your father, who was like my father, with many medical problems, I would automatically get more than if I were seeing a young, healthy person with a cold, no matter how big a history I did or how elaborate physical exam I did. Those are two of the three principal components on which doctors get paid now. But a person with, say, 3 of 10 chronic illnesses, a doctor should get more for that. And that would focus the attention of doctors on the people who really need the 4 years of medical training and 3 years of residency and all the rest of it, and leave the colds and coughs and colds for urgent care clinics.
Okay. Some practical suggestions. Let's take John Kingdon here in the middle.
I'm John Kingdon from the University of Michigan. Hi, Julie. I wanted to concentrate on the healthcare side and the revenue side in particular. As Senator Conrad said, the Social Security one is, as things go, easier to deal with, and maybe you could take that up first and get it out of the way. But anyway, on the healthcare side, you can try to wring all the inefficiencies out of the system as you can with all the list of things that you had. But as Bell said, you won't get a lot of money out of that, and so there's no way to deal with this without more revenue. And I can think of two kinds of revenue. One is, as you said, a drastic change in the individual income tax system. I mean, something like an individual income tax that has no credits or deductions, except maybe for the earned income tax credit, which would bring in a lot more money, and would also simplify the code, as it turned out. The other is a new source of taxation, and taking from conservative kind of thought about this, a new consumption tax, either a value-added tax or a national sales tax or something of that sort. And if you wanted to make it a little more politically palatable, you could create a healthcare trust fund, like the Highway Trust Fund or the Social Security Trust Fund, into which this new source of revenue would go, so that taxpayers would know that they're having to pay a new tax, all right, but they know what they're getting. They're getting health care out of it, and might include Medicare, Medicaid, and whatever new initiative there might be coming out of a new administration. But those are the kinds of lines along which I've been thinking, and I would hope this new commission would not rule out that kind of way of doing it, because I don't see any way out of the long-term fiscal problem without some pretty substantial new revenue.
Well, see, that's why you and I need to be on this commission, because we couldn't disagree more. First off, the EITC is one of the worst elements of our tax law, not in concept. Philosophically, it's a great idea. The only problem is the massive fraud in the EITC overwhelms the deduction, and I would not want to expand it until we address the fraud issues, and the fraud issues are politically very difficult to address. Secondly, turning to a consumption tax is a great idea if you put in place a mechanism to reduce the income tax at the same time. But if you simply put a consumption tax on top of an income tax, all you're doing is radically expanding the engines of government. All government moves to the left. And the rate at which it moves to the left, if you think of it as a train, for example, depends on how many engines you have on the train. And the engines are the revenue sources. And the only way you can control the rate of growth of government is by controlling the rate of revenue, in my humble opinion. And so adding a consumption tax, which is a very benign way to collect taxes in the sense that people don't feel it the way they do an income tax, it creates an engine for generating revenue which is huge. So if you didn't combine that with a significant reduction in income taxes, especially on working Americans, because consumption taxes are inherently regressive, you would basically, in my opinion, be just radically expanding the size of government. Now, can healthcare be addressed without new revenues? I think we ought to at least take a shot first at making healthcare as efficient as the market can make it. The Dartmouth studies are pretty overwhelming that there's a huge amount of misplaced resources in healthcare. It might be nice if we set up some incentives to reduce those misplaced resources and more effectively deliver health care in the process. Will we have to have some new revenues? Well, I presume that's why we're putting it on the table here with this commission. I suspect there will be a revenue component of any agreement that they come to. But I would hope that before we got into just expanding the size of the government through massively expanding its revenue sources through a consumption tax, we would take a hard look at ways of making the healthcare system more efficient, more cost effective. The interesting thing about these Dartmouth studies at the Wenberg Center are that they look at different regions of this country and they see utilization very high, for example, in Los Angeles, and the product that's put out isn't as good as the utilization level at the Mayo Clinic, and the cost is 1/2 times more, 50% more. Now, that's not entirely a function of the fact that people in Los Angeles want to go to the hospital. It's probably more a function of other factors which could be addressed through better incentives. And Senator Conrad has made the point for a long time, which is a very difficult point for a democracy to deal with, which is that, what's the percent? 40% of the cost of health care, especially Medicare, is in the last 6 months. How do we deal with that one? I mean, you get that under control some way. And I don't know how an elected official does, but Senator Conrad's right on with that issue. You know, that there are places we can look, I think, to deliver better health care. And we're not talking about reducing quality. We're talking about getting it out there in a more affordable and effective way.
Okay, time for one more question.
Maybe if I could just on this point, because I don't want to lose it. Boy, when I look at what we're spending on health care, I just don't accept that there aren't substantial savings to be garnered. We are spending almost twice as much per share of GDP as any other major industrialized country on health care. And I think there are enormous inefficiencies in this system. And I think for the work of a group like this to be credible, you gotta show people that you have brought efficiencies to the system, because I don't think it sells to have revenue added without clear, identifiable benefit. And I would strongly resist, if I were a member of this group, just putting more money into the healthcare system before we took serious steps for savings. On the revenue side of it, that's why I think you have to have all of this together. I don't think you can do Social Security on its own. I don't think you can do Medicare or the health care accounts on their own. Because the fact is, as you approach it in a budget, these things are all together. And I've believed that unless you convince the American people of the urgency of the situation that we confront, the seriousness of a failure to confront it successfully, you just won't have the support to do the tough stuff that's going to have to be done.
Final question.
My name is Raymond Adelman. I'm a retired physician and currently a beneficiary of Medicare, so I have a vested interest in the discussion. And, first of all, I'd like to... Is this on?
Yeah, don't put your hand
I'd
on
like
the
to
bottom.
applaud you very much on the development of a bipartisan group to address some of these issues, because this can't be a partisan issue. And clearly, Medicare and the healthcare system need massive amounts of reform in this country. It's long overdue, and the only way to address this issue is through a fair and bipartisan group that's willing to put everything on the table. I agree that there is a lot of waste in the healthcare system, and I've seen it myself as a provider. And one of the things that I would urge you to address is how to provide incentives to providers so they do reduce this waste. As a physician, it doesn't bother me one way or the other whether I order an MRI or an expensive brand name drug or refer my patient to 17 specialists. It's no skin off my nose, but it does definitely increase the cost of care, and there have to be incentives to providers to reduce that in an appropriate, fair, and safe fashion. Second, as somebody mentioned, the reimbursement structure for medical care is a piecemeal reimbursement, and clearly one's incentivized to do procedures because you get more money than if you don't do procedures. And if you look at the cost of cardiac care here in our neighboring area, Canada, or you look at any of the national healthcare systems in Europe, one of the reasons why there's such a difference between our percentage of procedures that are ordered in other countries is our reimbursement system, which again has been dictated by physicians, but I think that needs to be addressed. My major concern right now is the what I'll call the special interest groups. I mean, you're dealing with a healthcare system that now accounts for 16% of our GDP. It's over $2 trillion. That these healthcare industries have spent over the last decade well over $1 billion in lobbying and have tremendous amounts of influence. And if you're going to be able to reduce healthcare costs, you're going to step on the feet of a number of these different organizations. Incidentally, the other area that's an area that really needs addressing is the administrative costs, which currently account for about $400 or $500 billion of the healthcare budget, and that could be reduced as well. But how do you expect that your committee and your allies in the Senate and the Congress are going to be able to deal with the special interest groups that clearly are going to get some of their perks affected here?
Well, to begin with, this isn't going to be a magic wand. Maybe, as Senator Conrad said, in the area of Social Security, there are only 4 or 5 major moving parts. Maybe you can address that and make it actuarially solvent for 75 years. But healthcare is such a complex and intricate matrix, which is constantly growing, mutating, and changing, that there's no way this group is going to radically affect it the way they might its actuarial soundness. But if it could get 20, 30, 40% of that actuarial soundness back, that would be huge. And I think it can do that with policies which are, I could name 2 or 3 that I think could get there. But they're basically policies which, sure, they're going to impact people. Obviously, people are going to get less reimbursement, or they're going to have maybe less options, or they're going to have to pay more. And have higher tax burden. But I don't think this group, my perception is going to get down into the weeds to the level that maybe you as a physician would get into the weeds, or the physician mentioned to us back there who talked about how you set up the various reimbursement structure. I think that the attempt will be more general to systematize something. For example, the administration proposal that people with high incomes pay for a percentage of their Part D premium. That picks up a lot of money. And it's a legitimate approach.
As a drug benefit.
As the drug benefit.
Right.
Yeah. And there are things you can do on the provider side too that are not going to hammer the provider groups in a unique way and but is going to incentivize them to be more efficient, more transparency, more IT, more capacity for the purchaser to go to a central location and find out, is this hospital delivering better care at a lower cost than this hospital, so that they can send their insured people to that hospital. So there are ways we can do this, I think.
You know, it is phenomenal, the difference that exists in the current system. Senator Gregg mentioned Mayo Clinic, and of course that's in my neighborhood. My relative used to be the administrator of the hospital there, sister, who's a nun, and I looked at her hospital statistics versus the other major medical providers around the country. It's a phenomenal difference. And they're getting the best healthcare outcomes and with far less cost. Now, boy, I mean, we should be able to figure this out. I just personally really think the idea of adding a bunch more money into healthcare when we're already at 16% of GDP, as you referenced. I think the next highest country in the world is 10%. Most of the industrialized world is at 8% of GDP. So I think serious reform has got to be part of this effort.
Well, with that, please join me in thanking the two senators for part one of our program.
Pleasure, Larry. Thank you, Don. Nice to see you again.
And please remain seated for our second part while the senators depart.
Good luck to see you.
Do you want to use the podium? Or? No, I'm going to do a little introduction first. But
Thank you.
Oh, thank you very much. Great. Okay, well, welcome to part two of our program. This is the Congress Project Seminar on the Seniors Entitlement Crunch, the politics of Social Security and Medicare reform. We're very pleased to have joining us today Assistant Professor of Political Science at George Washington University, Kimberly Morgan, who has done extensive work on comparative social policy in the U.S. and Western Europe, as well as on women and politics. She earned her BA from Northwestern University and her MA and PhD degrees from Princeton University. And she was kind enough to prepare an original paper for this seminar, which is handout on the table outside, and it's also on our website at www.wilsoncenter.org. It's entitled Veto Player or Agent of Reform, Congress, the Politics of Social Security and Medicare. And following a summary presentation of her paper, we will hear from Julie Rovner, who is the health correspondent for NPR, and she's also a contributing editor to National Journal's Congress Daily. She won the coveted Everett McKinley-Dirksen Award for Distinguished Reporting on Congress for her coverage of the 2003 Medicare prescription drug bill's path through Congress, and that was a very interesting path, I might add. She is also the author of the critically acclaimed reference book, Healthcare Politics and Policy A to Z, and co-author of Managed Care Strategies. She began her reporting career with Congressional Quarterly Weekly Report. She's a political science graduate of the University of Michigan. Following these two presentations, we'll have some follow-up discussion among the panel, and then we will open the floor to questions, and we'll start off with Professor Morgan.
Thank you for that introduction. It's a delight to be here, reflecting upon these important issues. My paper was really motivated by another project I'm involved in. I'm writing a book about the 2003 Medicare Modernization Act, which added a prescription drug benefit to the Medicare program and made a lot of other important changes to Medicare. And in working on that project, one set of arguments that will be in the book has to do with the very important role that members of Congress played in the development of this legislation, that in fact it was really very much a congressional initiative rather than a Bush administration initiative as is commonly portrayed in media accounts about the reform. But in fact the Congress, I think, was very dominant in the whole debate and development of that legislation. And this led me to want to really reflect upon the nature of the Congress as a powerful force in American social policy making and what implications that has for federal entitlement policy. Now, I think for American observers, this is a kind of obvious or banal point, but from a comparative perspective, which is what I herald from because I do a lot of comparative research, it's really not that obvious because in most Western countries, parliaments are really not where the policy-making action is. The policy-making process is much more centralized in virtually every other Western country. Decisions are made within executives. They're made within governments headed by prime ministers, working with executive agencies like ministries of social affairs. And parliaments are really largely rubber stamps for these decisions made within a fairly small group of people making decisions about policy. In the U.S., by contrast, we have this Congress that is uniquely powerful in the Western world. And of course, this is very much inherent in our system of checks and balances. So what implications does this have for redistributive politics and policy? This is really the question I wanted to think about in this paper. The usual story told among academics about this is that the Congress is basically an obstacle to policy change. It's a kind of negative player in the world of policymaking, a sort of veto player against redistributive policy. In part, that's because our policymaking system is so fragmented. Because of this system of checks and balances, there are many points at which legislation can be blocked. Bills have to survive subcommittees, committees, House and Senate votes, conference committees, and then finally get presidential approval. But the second major problem that results from our the role of Congress in this whole process is that our policymaking system is very permeable to organized interests, as has been talked about in the previous hour. That we have thousands and thousands of interest groups in Washington, reasonably well funded, some extremely well funded, and whoever has the most money and or the loudest voice often tends to prevail, particularly given that the Congress offers so very many access points to these groups, 535 access points to be precise, basically to interest groups to try to have influence over the policy process. So the implications then of this fragmented and permeable political system is that it's very hard to institute new social programs. Redistribution, by definition, takes from some and gives to others, and those who are being taken from are obviously going to mobilize to try to block new redistributive programs and take advantage of the many access points that our system provides. But then also, once a social program does finally manage to get enacted, like Social Security or Medicare, powerful interests are likely to form around it that make change very difficult. Universal programs, in particular, are very hard to reform. In the case of Social Security, about a quarter of Americans get some income of some kind from the Social Security program, be it from the benefits, Social Security benefits, survivor benefits, or disability insurance. And in the case of Medicare, it provides health care for 44 million seniors or disabled people. That's a huge number of people, obviously, but is also a major source of income for politically influential groups like hospitals, doctors, medical supply, equipment suppliers, and now also the pharmaceutical industry. So a lot of very powerful interests benefit. The result then is that every state and congressional district is full of people and industries that benefit from these programs, making them particularly difficult to reform, and thus leading to the expectation, I think that's been confirmed again and again, that legislators tend to tread very cautiously around these so-called third rail programs. So to sum up then, the conventional view has been that Congress is mostly a kind of negative force or a veto player in the social policy process. And the history of efforts to reform or change Social Security and Medicare offer plenty of support for this point of view. Attempts to make large cuts in Medicare or Social Security early in the 1980s, or in the 1980s by the Reagan administration, were very much contested. Reagan's proposal to make pretty significant cuts in Social Security, for example, in the early 80s, was very vigorously attacked by Democrats and Congress and defeated quickly. Efforts also to increase payroll taxes to deal with the problem have not gone anywhere. Basically because both benefit cuts and tax increases are very easily politicized, and Congress is a very key venue for the politicization and blockage of any type of reform in that direction. The one example of successful decision-making around the Social Security program in response to the crisis in 1983 that the trust fund faced, it was notably the success was precisely because decision-making was taken outside of the normal channels of congressional decision-making, basically behind a commission discussed very nicely in Don's paper, that the commission basically provided political cover for a lot of behind-the-scenes negotiating. And what really was key to the ability to devise a package of reforms was to take the process away from the Congress, in a sense, to do some backroom negotiating, and that enabled then the development of a package to respond to the 83 crisis. Thus, I think there's a lot of evidence to support this kind of conventional picture of Congress and its role in the politics of Social Security and Medicare. However, the case I want to make in the paper is that institutional changes in the workings of Congress and shifts in the larger context of American politics have actually quite altered this picture of Congress and its role in federal entitlement policy. Whether that gives us room for optimism or pessimism, not quite sure, but I do think that the politics of entitlements have been changing. And that basically Congress has become more than a kind of veto player in the policymaking process and much more of an active agent of reform. Now, first, some of the institutional changes, I think very important has been the development of the independent budgeting capabilities of the Congress since the 1970s, the creation of the Congressional Budget Office, the whole budgeting process of developing budget resolutions and reconciliation, the creation of the budget committees, of which we had the representatives from the Senate here today, really has enabled overall planning in the Congress and a more sort of cohesive policymaking process than had existed prior to that period. One result then has been some centralization of policymaking power within the Congress around the budget process. In addition, there's been overall a strengthening of congressional parties and their leadership, a process that has been going on since the 1970s, with a series of reforms to the workings of congressional parties since then that has continued in the 80s and the 1990s. And as I detail in the paper, one consequence then has been stronger leadership, a stronger role for the party leadership, particularly in the House, but now increasingly in the Senate, which is, I think, more and more able to really set the agenda for the entire party in the House and more in the Senate, to then push legislation through the various institutional hurdles that exist and build majorities for passage. So these are some of the institutional changes that I think have really started to centralize more power within the Congress and enabled more activism on social policy issues. In addition to this have been some larger political shifts that are related in part to the institutional changes, namely the growing ideological homogeneity of the two parties and resulting polarization of politics in general and in the Congress. It used to be that the Democratic Party was divided between a liberal and conservative wing. One could say the same for the Republican Party. But now both parties are more ideologically uniform, reflecting, I think, more ideologically uniform constituencies for the two parties. So these constituencies are basically electing members of Congress that are within each party more alike to each other than they were in the past. This has then contributed to some of the institutional changes I discussed, in that as the members of each party have more uniform goals, they're more likely to agree that they want to have a powerful leadership that can then enact the policy goals that they share. So this has really contributed to this drive to strengthen parties in Congress and give them more power over decision-making and agenda setting. But what we've also seen is then a sharpening of debates over many issues, including in particular Social Security and Medicare and entitlements more generally, as the parties have drifted further apart and bipartisanship has declined, particularly in the House, but I think also in the Senate. The differences between the parties have become much sharper, and the tenor of the debate around entitlements has become much fiercer, particularly given the fact that the margins of control in Congress have been very close in both the House and Senate. There's been pretty rough competition between the two parties for control, for a majority. And there's been a lot of competition then over areas of difference like entitlements, with each side trying to show that its policy vision and agenda is superior to that put forth by the other party. In short, then, the two trends have been, I think, the centralization of power within Congress, reducing some of its fragmentation and permeability, but also political polarization, declining bipartisanship, and a sharpening of differences between the two parties on many issues, but including on entitlements. The implications then for federal entitlement policy are, I think, first, a Congress that is much more determined in many ways and a more capable policy-making actor than in the past. I think one could even argue that the Congress, with this more centralized policy-making process, has been at times able to withstand some of the pressures of organized interests. I don't want to push that point too far because I think it would arouse considerable skepticism. But I think the example that's often given is the development of the Medicare prospective payment system in the 1980s and 1990s, which cut reimbursements or really squeezed reimbursements to hospitals and doctors considerably, and really showed that the Congress was capable of stiffening its spine against these powerful interests. Now, like I said, I don't want to push this too far because I think one can find myriad examples of pressure groups having success in lobbying and getting what they want, but that there is some evidence that at times Congress has been able to really resist these pressures, even by these very well-heeled, well-funded groups. But what I think we also see is that the congressional political parties and their leadership have been able to act more independently, more vigorously to really achieve electoral and policy goals. That the two parties, as I indicated, have quite different stances on entitlements, that they're competing over these stances often in elections, and so we've seen some increased policy activism emerging out of the Congress to try to deal with the entitlement problem. I give several examples in the paper from Medicare policy in the 1980s and 1990s, and I argue that this trend has really culminated with the Medicare Modernization Act of 2003, which, as I mentioned before, added this prescription drug benefit to Medicare. But it did so in a very distinctive way because it was a bill crafted by Republicans and almost entirely supported only by Republicans, and that the drug benefits are provided by private plans that compete for the business of seniors, and the bill also increased the role of private insurers in the Medicare program. So basically tried to move Medicare further along towards being a system of competing private insurance plans, which is very much the vision that many on the conservative side have been putting forth. Now, typically in the media, this has been portrayed as the brainchild of President Bush and Karl Rove and others in the administration. But actually, Bush came to the issue of prescription drugs and Medicare reform, I think, well after Republicans in Congress had already not only devised their own legislation but voted on it, and that various White House proposals for this legislation were repeatedly rejected. That instead it was the leadership in Congress, particularly Speaker Hastert and Majority Leader Frist ultimately when he came to power in the Senate, that played a critical role in crafting this legislation and pushing it through, and that it was very much a congressional initiative. So in short then, I think what we see is increased centralization of power in Congress, growing political polarization, and together, and the latter really spurring this competition and activism on federal entitlements by each party. What does this mean then for the future of Social Security and Medicare? Well, we see reforms in the years ahead. Well, I would argue that still any kind of reforms do face considerable obstacles, even though the Congress has become more centralized in a lot of its decision making. Still, it's far less centralized than the political systems of other countries, and so the system I think is still sufficiently fragmented that it's hard to envision really major controversial reforms being pushed through. Moreover, I think some reform ideas are just so unpopular, I don't think they're going to go anywhere, like investing Social Security reserves in the stock market. I think a lot of people, the public opinion data shows that people are very opposed to that. But similarly, carving out a system of private accounts out of our payroll tax system, I think also would be pretty hard to do because there's not a lot of support for that, I think, out in the public. Nonetheless, I think what impressed me in my study of the 2003 Medicare reform is just how determined Republicans were to enact their vision of Medicare reform. That even though it fell short of their goal to really transform the Medicare program more fundamentally into a system of competing private plans, it nonetheless was a pretty significant reform, and it was done with very slim majorities and really showed what a strong and creative leadership is capable of doing, of pushing through a reform. So my prediction then would be that whatever party has control, even with a fairly slim majority, may try to institute its own vision of reform, even if it has to do so through somewhat gradual and subtle means, but will try to advance the particular vision that has been developed on each side. That on the Democratic side, we can expect a continued squeezing of provider payments through Medicare. I think they're probably going to go after prescription drug payments and try to go after the industry on that. And that if faced with a real push for some action on Social Security, we'll really try to do something to raise the ceiling on payroll taxes, basically to make the funding of Social Security more progressive. On the Republican side, I would expect to keep seeing efforts to institute market-based reform, even if they have to do this in stages through things like further promotion of private insurance plans and Medicare, or perhaps looking into things like adding on private accounts to Social Security and other ways to kind of shore up private retirement security. Now, this may seem like a kind of obvious conclusion. The Democrats, when they come in power, will try to do what they want to do. The Republicans, when they come in power, will try to do what they want to do. But I actually think it's less obvious than one might think, because in the past one would have said that these programs are third rail programs that nobody wants to touch, that everybody is treading cautiously around them. But I actually think this third rail characterization is not really true anymore, or at least it's less true than it was in the past. That each side now has an electoral base that's more uniformly supportive of the particular agendas that they've developed towards these programs, and so electoral punishment is somewhat less of a threat. For that reason, then, I would expect more reforms in the years ahead, but I would not expect them in the sort of bipartisan way that the senators laid out, but instead would expect more partisan reforms, that whoever manages to wrest enough of control of the House and Senate when they face an entitlement, the entitlement crisis in the years ahead is going to try to push forth a very partisan agenda and ram it through rather than seeking to build bipartisan support in the way that the senators had hoped. That would be my forecast anyway. And with that, I will turn it over to Julie Rovner.
Julie?
Thank you, and actually that leaves off in the place where I'm just going to start. I want to talk a little bit about what I call the medical industrial complex, and those are the healthcare providers. And let me just pick up with one comment that Kimberly made, which is about Congress being sort of less or more willing to go after healthcare providers. I think that's probably not too much the case. I think the last time Congress really went after the provider community was in the 1997 Balanced Budget Act, and they spent the succeeding 3 years years giving back money. We called those the Medicare give back bills, and they just came one after the other after the other. My favorite comment during that period was from Tom Scully, who some of you will probably remember as the head of Medicare during the Medicare prescription drug battle. But in fact, before that, he was the head of the Federation of American Hospitals, the private for-profit hospitals. And when they were calculating all of the cuts that had come as a result of the 1997 Balanced Budget Act, when it turns out they'd gotten a little over-aggressive and cut more out of Medicare than they'd intended to, he was sitting in a press conference once and he said, "It's our money and we want it back." Which is basically how the healthcare providers view Medicare. I think it says a lot about the politics of entitlements, which is that all of that money is somebody's income and that you sort of handle it at your peril. And I think that's sort of the chief obstacle to doing things. Not so much about Social Security, and I think that's why you always hear, lawmakers and the senators both said Social Security is a lot easier because Social Security generally isn't somebody else's income. Social Security is just the taxes that we pay. Medicare is somebody's income. That money is always going to some provider. So Medicare is much more politically delicate. Now, when I first started covering Medicare back in 1986, I was in my 20s, and 2010 seemed really, really far away, and I was really, really confident that we'd have Medicare all squared away before the first boomers got their Medicare cards. Well, now I'm about to get my AARP card. The first boomers are about to get their Medicare cards, and things really aren't nearly as taken care of as when it comes to either Social Security or Medicare, and as you've heard, particularly Medicare. I think one big problem when it comes to Medicare is that Congress is often called on to be the micromanager of Medicare in the name of budget policy. I can't tell you how many times over these last 22 years I've had members of Congress and senators kind of come up and whisper to me that they're not really qualified to say how much Medicare should be paying for oxygen or intraocular lenses or how much nurse anesthetists should get paid compared to anesthesiologists. And I have to agree, they're not qualified. But if you peruse any budget reconciliation bill going back to the mid-1980s, you'll see that Congress has set every one of those policies, repeatedly, in fact, and all in the name of achieving required budget savings. That's the mantra of budget reconciliation. In other words, meeting those budget targets often begets bad policy, or at least ill-informed policy, or heavily lobbied policy. Take your pick. And we're about to get yet another illustration of that. In just the next couple of weeks, I think the deadline is June 30th, Congress is going to have to figure out how to prevent a 10% cut in doctor pay. An unintended cut, I might add, stemming from what just about everyone agrees is a flawed formula that was set by Congress, but we won't go into that. And in the name of fiscal responsibility, since we have reinstituted the pay-go requirements, meaning if you're going to add money to the program, you have to take money away, they're going to have to come up with somewhere in the neighborhood of, depending on how long they decide to delay the cuts this time, $50 billion in offsets. Now, this is a lot less than the trillions that Senator Gregg was talking about, but it's still a lot of money. And it's touched off a furious round of what one of my health lobbyist buddies has once dubbed negative lobbying, or the effort to not get cut. See, in healthcare, we don't lobby for money. We lobby against losing money. Now, this is terrific if you happen to be The Hill or Roll Call or Congress Daily and you're getting the ad revenue, but I'm not so sure it makes for the best health policy. I think one of the real big problems with this, besides the fact that Congress is so busy doing this, setting policies for which they confess that they are not qualified, is also that they get constantly mired in the minutia, and it never really gives them time to look at the big picture. They're so busy digging out of last year's hole and plugging the immediate leak that they never really manage to take the time to figure out how to rebuild the dam. Now, of course, it isn't that they don't know the dam's threatening to burst. You just looked at all of these charts that Senator Conrad is never without. But as we all know, Democrats and Republicans have very different views on how to fix Medicare. Democrats say you can't fix it without fixing the whole health care system. The problem with Medicare isn't Medicare, it's rising health costs in general. In fact, the Congressional Budget Office just pointed this out last year in its long-term health policy paper. Peter Orszag pointed out that actually the baby boomers, those 78 million people about to descend upon Medicare, are actually a much smaller increment of the rising healthcare costs than simply added technology and the added costs that healthcare growing faster than the rest of the economy. If you look at his chart, those added baby boomers are about this big, and the added cost of health care over the rest of the economy is about this big. So we have a bigger problem than just those baby boomers, and we have a bigger problem than just Medicare. Republicans, on the other hand, as you heard from Senator Gregg, want to make Medicare more market-oriented, which of course is what led us to the Medicare Advantage program, the private plan program that we got as part of the 2003 drug law, which of course we know is costing more, not less, than traditional Medicare, because we're overpaying it to try to get more people in. Which leaves us where? Well, 2 years from the first boomer Medicare recipients, with a really big and growing fiscal problem, and still searching for a consensus on how to fix it. If it really takes a crisis to force changes in Medicare, I think it's fair to say we're getting pretty close. Now I'd like to comment just briefly on the commission proposal that the senators have. I think one thing that lawmakers sometimes suffer from, and I guess this may be a good thing, is a selective memory. It keeps them, I guess, from getting too depressed. They tend to remember the things that work and not the things that didn't. I, on the other hand, as a veteran of many of these commissions, have an entire bookcase full of thick reports of all the commissions that didn't work, meaning that they came out with a thick report, they had a big press conference in a room just like this, and they issued that report, and we all went home and wrote stories on it, and that was the last time you ever heard from that commission. I think sometimes even the commissions that everybody remembers as the ones that work maybe didn't work quite the way you remember. The Social Security Commission, everybody remembers the Greenspan Commission, right? That was the one that saved Social Security in 1983. It didn't actually work. That commission crumbled. In the end, it was Alan Greenspan and Senator Moynihan and a couple of people from that commission who got together in the dark of night and hatched up the plan that ultimately fixed Medicare. But it wasn't the commission itself. And in fact, the Andrews Commission, which wasn't really a commission that Senator Conrad was talking about, that was also prompted by a crisis. I believe it was somebody will correct me if I'm wrong, I think they were looking at a really big sequester that year, and they needed to find a way to offset it, and they hadn't had any luck. So they took the congressional leaders and Senator Sununu's father, who was then Bush 1's chief of staff, and they all went out to Andrews Air Force Base, and they got this big deal, and they came back and they said, this is going to be the reconciliation bill. And I remember I'd been called back, I had a horse show, and I was called back and said, you got to write this up. And I looked at it, the Medicare part, and I said, but this can't pass. And they said, the budget reporter, I was at CQ at the time, the budget reporter says this is going to pass, this is the deal. And I said, you don't understand, this can't pass the House. And they said, just write it up. So I spent about 6 hours writing it up, and it went to the House floor, and it failed because the Medicare stuff couldn't pass. And they had to go back and rewrite it later. So not all these successful commissions were all that successful either, although in the end, I think the deal that came from Andrews just got tweaked a little bit, and it did pass ultimately. But this is not to say that a commission proposal of the sort they are proposing can't work. I think it's just to underscore what we really all already know, which is that if this was easy, we would have already done it. Thank you.
Kimberly, would you like to follow up with anything as per Julie's comments?
Actually, I'd be interested in hearing from the audience.
Okay. Well, let's turn things then over to the audience. Please state your name and affiliation. Wait for a microphone. Gentleman on the aisle here, Susan.
Great. Hi, I'm Mark Goldwine from the New America Foundation. This question is for Dr. Morgan. You described sort of the difference in congressional action on Social Security and Medicare as institutional change over time, but I think you're sort of failing to differentiate between policies that are retrenchment policies and expansionary policies. The Finance and Ways and Means Committees were very involved through the 70s in expanding Social Security, and again, I think the Medicare prescription drug plan was an example of expansion, but I don't think we've seen any congressional action that I can think of where retrenchment was involved. So could you comment on that, please?
Yeah, I think an example of retrenchment would be the 1997 reconciliation process that led to major cuts in the Medicare program, very significant cuts. Those cuts had initially been proposed by Speaker Gingrich, and I think many people would point to Gingrich and the Contract with America and the sort of resolve of Republicans to make changes to entitlement programs as really representing this process of centralization of power within a party leadership determined to push through a particular agenda, even a kind of radical or dramatic agenda of dramatic change. That failed in 1995, as you might remember, because of deadlock with the White House, but then that was really what started this whole discussion and ultimately culminated in some actually fairly similar looking cuts in 1997 to Medicare and Medicaid. So I think that is an example of retrenchment.
And remember, every single budget reconciliation bill that had an ad in a health care program also had to have a revenue source. So that's sort of the source of this idea of negative lobbying. There were often health care providers who saw that's what I was talking about in terms of this oxygen policy and, whether anesthesiologists were paid in 15-minute increments. There were lots and lots of little nips and tucks and cuts here and there. So they were intimately familiar with retrenchment, even if it didn't seem like a big major thing. There were things that raised costs for beneficiaries that were kind of painful. There were definitely cuts to provider payments within the Medicare system and other changes that raised money and therefore were used to pay for other things.
Yes, on the aisle here.
Hi, I'm Shelton Williams from the Osgood Center. You've talked about the congressional role in this, but we're in the middle of a presidential election. Does the president matter? And if so, which one will do what and form what kind of leadership?
I just did a story on this, actually. All three of the remaining presidential candidates have been kind of ducking this issue pretty assiduous. Well, that's not fair. John McCain has talked about it a good bit, although he tends to conflate Medicare and Medicaid on a fairly regular basis. But one of the things they have all talked about is something that they want to do that's kind of the same, and I think you saw the list that Senator Conrad had, which is more comparative effectiveness research, more e-prescribing, more chronic care management. Those are, what we call the low-hanging fruit, which I think Professor Sawhill pointed out are all good things to do, none of which are going to save enough money to get us out of the fiscal hole that we're in. So I think everybody agrees with those sorts of things. But as a general rule, you don't go out running for president proposing, the really tough kind of decisions and trade-offs that people are going to have to make. Now, in fairness to the Democratic candidates, they will tell you that the problem is health system-wide. If you fix the overall problem with the health system, that will help lower costs and help fix Medicare in and of itself. And Senator McCain, I guess his theory is that if you make healthcare more market-oriented, that will bring down costs also, and therefore also bring down Medicare costs. In fact, he has said that. So they all have this sort of bigger picture of the healthcare system that will include Medicare. But they're not talking a lot about what to do precisely about Medicare.
If I can just add something, I also really think that broader healthcare reform is really going to eat up the policy space in the next couple of years, regardless of who comes into power, but especially if a Democrat comes into office. I just think that's going to dominate, and any action on Social Security seems very unlikely to me because there's no really pressing need in a sense. I mean, there's a need if you take in all the PowerPoints that have just been presented in the last hour, but there's not a really pressing crisis. And in terms of Medicare, something's going to have to be done in the next 4 years, as there's always something has to be done on Medicare, probably nibbling away at bits and pieces to sort of make it, cobble something together to get us through in the short run. That's what I would expect. And no one's going to put forth a platform on that. I think, as Julie said, no one really wants to talk about what they would do in that area.
Let me ask a political question that's related to that then. Let's assume that maybe Congress gets a bigger Democratic majority and maybe a Democrat is elected president. Do you think that president will go along with the idea then of a bipartisan group of the type that Conrad and Gregg talked about here, or will the president say, let me come forward with my own plan and let Congress deal with that? In other words, will they take the more political route that you seem to be indicating Congress is more likely to do, or will they at least initially go for some type of bipartisan cover on this?
Seems unlikely to me that that a Democrat coming in with a reasonably sized majority would want to engage in bipartisanship on something like entitlements. That seems very unlikely to me. Like I said, I think broad-based healthcare reform is what they want to do, and I think that's going to just take up everybody's energies, at least in the next 2 years.
On the other hand, I mean, there are the new president's going to have an awful lot of early problems, fiscal problems. You've got the Bush tax cuts coming due. You've got an AMT problem, as Senator Conrad, alternative minimum tax, and you've got S-chip. That was a nice little loaded gun that
state children's health insurance.
That Senator Grassley sort of forced through last year. That comes back up for renewal next March. So right after the president takes office.
And that's going to be too soon, obviously, to do something major on health reform. But that's going to, all of those, things are going to require finding a good portion of money fairly quickly, and it's going to make it very difficult to do some kind of health reform fast. So I think the attraction of having a high-level commission might be, it might be a way out of that initial box. I'm not suggesting that President might want to give away that much power. I'm just saying that might be a way to get it off the front burner.
Well, it would fit with some of Obama's post-partisan politics that he's talking about, but we'll see. Other questions from the audience? Yes, right here.
Hi, Eleanor Fink, a longtime member of the Conrad Coalition and a former staffer with Kimberly on it. How is any of these tough choices going to work without popular support from the voters? And given the lack of any choices, people of making any tough choices over the last, 15 years or so that I interested in the field, what's the crisis that's going to produce that voter support?
Yeah, that's a hard one. I think looking back at the commission in the early 1980s, or the effort to respond to the trust fund crisis, what was really key, and I think what's also been key in other Western countries grappling with big pension programs and healthcare costs, has been a lot of sort of backroom negotiating, basically coming out with a package of tax increases and benefit cuts that sort of try to share the pain very broadly, and then coming out and trying to, and basically saying, this is what we've negotiated, and hope that they can get it past the public without the public being either too aware of the costs, or that the pain is spread broadly enough that everybody can be said to be contributing in some way, that everyone can kind of feel like this is shared sacrifice. But that the process probably has to start from sort of behind closed doors and then come forward into the light rather than the reverse, which maybe doesn't say anything great about democratic accountability. I'm not sure what it says about the workings of democracy, but I just think, as the senators point out, when you start out in the open light putting forth these proposals, they're just so quick to become politicized, for sort of extreme claims to be made about them, for people to get riled up, that it becomes very difficult then to sort of come together around a package of shared sacrifice. But that when you start the process from more behind closed doors and work out an agreement that various factions think shares the pain, that you can then come forth and present that to the public and hope that you can maneuver around all the sharks in the water to try to get that through.
I think the people who are working on health reform would like to think that you can put together a package that has, enough winners and losers, or more winners than losers, so that people will see that in the end, it is to the benefit, even though there will be some losers. That obviously, in the case of the Clinton health reform plan, there probably were more winners than losers, but the losers were louder. That was certainly the case in the Medicare Catastrophic Coverage Act, which was designed intentionally so that there would be far more winners than losers. But in the end, the losers were so loud, even though there were so few of them, that I think the Congress was sort of browbeaten into repealing that, even though, if you looked at the way it was actually designed, the losers were so few, and yet members of Congress who were not in on designing it simply didn't understand that. That was a real failure of education, and a real failure of education not just of the public but of members of Congress. But they went to their town hall meetings, and just the few people, and I think it was also people who it never took effect, so people didn't realize that they were actually going to do better. It just took off on its own. So I think there's an enormous education process that needs to go on. But I think, as to the beginning of your question, it has to get really, really, really bad before I think people are willing to make sacrifices. That's what we've seen. It has to get to a crisis level. What's a crisis level in healthcare? When someone, gets run over by a bus and there's no ambulance to take them to the hospital. And are we there yet? No. How soon are we getting there? I don't know.
I haven't seen any polling data to indicate to what extent the public is aware that there is this type of a crisis, or not a crisis, but even a financing problem that needs to be addressed. But I know the Concord Coalition and others have done their fiscal wake-up tour, a lot of town hall meetings around the country. President Bush has done a lot of this. I think Clinton before him did quite a bit too, and you just don't seem I mean, it doesn't seem to be that kind of public awareness or push for Congress to even move in the direction, let alone coalesce around any particular solution. So, I don't know what that's going to take, but you would think that there'd have to be some type of public concern or some kind of public opinion behind taking some action before Congress is going to really, going to move on this. I don't know, but that's just my gut reaction. Other questions? My gosh. Yes, Robin?
I'm Robin Muncie. I'm a fellow here at the Wilson Center. I'm wondering if the requirement in the legislation for the commission that whatever the commission proposed would have to be brought to a vote, an up or down vote in both houses. If you think, Julie, that makes this commission more likely to have some kind of effect than other commissions, or if that's not impressing you at all.
This commission sounds very similar to the Medicare commission that Senator Breaux chaired in 1999, I guess it was. And boy, that turned out, and it did. It had Democrats and Republicans, and they were almost all from Congress, except a couple of presidential appointees. And that was politicized from the word go. And in the end, they missed getting their supermajority by, what was it, 1 or 2 votes. And in fact, what they proposed was fairly close to what did become law. So I guess they didn't do, it wasn't entirely for naught, but it's just the idea of that much centralized power in that few hands with no amendments seems to be an awfully big leap of faith by the rest of the Congress and the administration, and to require a vote, an up or down vote, on the Senate floor. I mean, Senator Gregg was correct. Even the trigger that they have now, which did get watered down, there is no requirement for a Senate floor vote. There is a potential requirement for a House floor vote, but it does not have to come to the Senate floor. And that was the one thing that they took out of it at the end.
My introductory essay is entitled, "Is Political Will on the Hill Out of Commission?" And I mean that in two senses. Has Congress lost the will to take action, and does it really have to depend on commissions to at least jumpstart it and get it moving in the right direction? And I think one of the things, in just doing my brief survey of some of the past efforts, is even though sometimes commissions don't come to agreement themselves, sometimes their recommendations land with a thud on the doorstep of Congress, that down the road you'll see bits and pieces of these things picked up again by Congress and enacted in reconciliation or elsewhere. And so it's not like the commissions have been a complete failure. You just don't always credit them with having at least thought about it and come forward with some recommendations. So I think it supports John Kingdon's whole idea of these garbage cans with solutions, one with solutions and others with the problems, and sometimes they get together and the window of opportunity opens and these things can get enacted, but it's very chancy, very iffy, and that's the way Congress operates. But I think the fact that the people sometimes demand something makes a big difference, and as has been pointed out here, unless they really sense there is some kind of an imminent crisis, they are not going to be pushing Congress hard to take any big bites. I think we had one more question in the front here, if that's still alive. Yes. The good doctor.
Thank you. We doctors always have to have the last say.
Mm-hmm.
I actually thought the Medicare Pharmaceutical Act was really a triumph for the pharmaceutical industry and its lobbyists. The fact that one couldn't use the power of Medicare to negotiate down drug prices, and clearly the VA does that. If you look at brand names here and brand names that you buy in France and Germany from the same pharmaceutical companies, these people pay half to a third to a fifth of what we have to pay. So I'm again very, very concerned about the power of these various lobbyists in dictating what's going to go on now and in the future, pending the time when we do fall over the cliff and decide we really do have to have some real substantive health care reform.
It's interesting. The original Medicare Act in 1965 adopted what some people have called a permissive regime, a payment regime towards hospitals and doctors, that basically, in order to get them on board with the creation of the Medicare program, put in all kinds of provisions that basically said the government would not, that basically the providers could charge what they wanted. As long as it was reasonable, the government would reimburse it, and there wouldn't be any effort to really kind of clamp down on the prices that they charged. And that, of course, led to tremendous medical inflation in the 1970s, and then led in the 1980s to the development of the prospective payment system, which sought to really reverse that and really clamp down on provider payments. Now, whether or not that's been successful there's a lot of debate. I mean, as Julie pointed out, there's an effort to clamp down on provider payments, and then there's a rollback as soon as there's any kind of leeway, and they have a real mobilization of the various interests to get their payments up again. But nonetheless, I think it showed that what was permissive in the beginning, for fiscal reasons, ultimately had to then become very constrictive. That faced with medical inflation, with deficits, basically Congress decided that the only way they could deal with it was to try to clamp down on providers. So the question would be whether or not the same fate will befall the pharmaceutical industry. That similarly, it's a very permissive payment regime for them that they clearly wanted and pushed very hard for and got. And having them on board, that legislation was critical for it to pass. If they had really mobilized against it, it probably would have been hard to get it through. So one could say that once again, there was this permissive payment system put in place, but will it really last? I'm personally skeptical, particularly with the Democrats in power. I think they're going to go after that. I think
they already have. They passed it in the House and installed in the Senate to allow for the negotiating down the drug prices. So.
Yeah, so that's kind of what I would forecast. Now, if Republicans regain control, then yeah, I don't think they're going to, obviously they're on the side of not having price controls or negotiations or anything. But I do think it's a target for the Democrats. So I actually think the industry is